Hi everyone, I'm Rachel. A very warm welcome to your Midlands Analyst Network Huddle, and it is a beautiful day here in Stafford, and I hope it's very nice where you are too. So for any new people, and I know there are some, we hope you find these fortnightly huddles useful by sharing skills and learning from each other's knowledge and experience. But also, and I've said this before, I hope you'll find these are just a very, very nice place to be and an opportunity to hang out with like-minded people. So there's more info about why we set the network up and the role of the huddles in the file section of the Teams channel, and we're always looking to improve them. So do contact me if you've got any fabulous ideas or if you'd like to contribute. Anyway, thank you very much for coming today. It's always wonderful to see you all. And before I hand over to Fiona and Seb, who are going to be talking to the title of Economic About, this is the last huddles. So I'm just going to scare you now. You're going to be talking about shopping in Tesco's. Yes, you're going to be talking about the Health Foundation's network data lab in a moment or two. But before I do that, I do have a couple of questions for you on Menti, which I'll give you the code now. And while I do that, which is 48576196, so that's 48576196. And while you're making your way to the land of the Menti, I'll just remind you that we.
Sorry, can you say that again, Rachel? I didn't catch it.
So I do it so fast, and I know when other people do that, I go, slow down. What's the rush? 48576196. Of course, if I shared my screen, it would be on it, but I will do in a sec. So I would just like to say that, reminding you that we are recording today's session, and we'll make the recording available after on the Teams channel and on the website. We're going to be finishing about 12, and if you've got any questions for Fiona and Seb, you can pop them on Menti. There'll be an opportunity for you to do that there, because I know most people can't access the chat box. Just for your info, Fiona and Seb, the chat box is only available to a certain proportion of people. I don't decide. It's a mystery, but that's how it is. So please do keep yourself on mute unless you want to say anything, of course. And just a reminder that these sessions are for you, and we like to keep them as informal, but hopefully as informative as possible. So before we do kick off, I'm just going to share my screen. And here we have Menti, and I can see a few of you are arrived here already, which is marvellous, and you're telling me that you're here by clicking on those little pictures. Okay. So just a couple of questions for you here. So I asked you this, I'll probably ask you this like every 6 months. So I'm, again, interested to know how many people are working from home. How many people are, in fact, not working from home and are working in the office. So we can see from our representative.
You didn't give 0 as an option, Rachel.
Oh, what a silly Billy. Yeah, so right, okay. If you are 0 working from home, you are not represented on this. This is clearly not an extensive survey, but it does give an indication of how many people are still working from home. So yeah, well, I've got no way of asking people now unless I stop it and restart it, and I'm not going to do that. So it does feel like most people are still working from home, and that's me too. Although our new offices will be ready soon, so I might be venturing into Birmingham at some point. Okay, thank you. So I'm now going to ask you, so if you could just note down your job, your role, and your organisation. So this is going to let Fiona and Seb see who's in the room. So who are our audiences today? Who's going to be learning about the networked data lab in a moment or two. I'll give you a chance to type because I've been lazy and I haven't given you multi-choice options. Health Foundation, yes, you're represented here today. Excellent. So you can see some of the organisations which are well represented. Strategy Unit, good. Well done, colleagues. Good to see you here. CSU as well. We've got plenty of analysts. We have healthcare analysts. We have public health analysts. And I'm going to get a bit closer now because it's getting a bit small for me. So sorry about that. So we have analysts who are specialists in cancer, health economics. So a lot of analysts, guys. So a lot of analysts, which is great and expected from the Midlands Analyst Network. Okay, so intelligence analyst is the most popular at the moment. I'm looking for lots of different versions of analysts. Okay, marvelous. Well, I'm just going to move this screen on to one which allows you to pop any questions that you've got for Fiona and Seb. Meanwhile, I will stop sharing my screen and I will hand over to, are you first, Fiona? Fiona, over to you.
I'll kick stuff. Thank you, Rachel. Yeah, thank you for having us today to talk about another network, which is the Network Data Lab. I'm just going to share my screen and ask the obligatory, can you see my screen?
Yes, I can.
Great, thank you. Yeah, so I'm here with my colleague Seb today, and I'll kick us off by introducing the Network Data Lab, and I'll tell you a little bit about why it was set up and how we work together with our partners. And then I'll hand over to Seb, who'll give you a flavour of the types of problems that we work on. And he'll also showcase some of the resources and tools that we have developed that we think will be of particular interest to this audience here. So we are both part of the data analytics team at the Health Foundation. The Health Foundation is also funding the Network Data Lab. And just as a very quick intro, the slides moving on? No.
Not yet.
Just a sec. I'll figure this out. Here we go.
Yeah.
As a very quick intro, the Health Foundation is an independent charity committed to bringing about better health and care for people in the UK. And Seb and I are both part of the data analytics team at the Health Foundation. As you're all well aware, there are some really big challenges facing health and care in the UK, even more so over the last couple of years. And at the same time, what we're seeing is really rapid developments in analytic and the use of data and data-driven technology. And our aim in data analytics is to make sure that the impacts are positive and that everyone's health and care benefits from analytics and data-driven tech. So the NDL was set up back in 2018, and lots of things have changed since, but I think there are still some, the background that I'm going to take you through now probably still applies. So there's a need to better understand problems facing the NHS and patients, and as we all here know, data and using data is a really important part of doing that. And linked data sets in particular can be the source of a really valuable source of insights. You will all know this. What I mean with linked data is data sets that share a common identifier across records, for example, from primary care, secondary care, community care, and social care. And what that enables us to do is that we can follow patients through the health and care system and get a much more complete picture of their health needs, their outcomes, and inequalities within that. And taking it even a step further, by linking in data from wider public services, we can help to get a better understanding of the impact of the wider determinants of health. And the work of the data analytics team at the Health Foundation over the last 5+ years and many others have shown just how important linked data is to support national policy decisions as well as local decisions on health and care, and that much more investment and support is needed to accelerate the development of these data sets. Even though I should acknowledge that over the last couple of years, in the context of the pandemic, a lot has happened. So What is still true, though, is that the data landscape, the health and care data landscape in the UK is highly fragmented, and there are only a small but growing number of linkages that really cover the whole population at a national level. And many of you will be aware of datasets like HES and CPRD. But at the same time, creating new linkages for individual analysis projects and questions is really slow and resource intensive. It can take years to get a new linkage approved. And that makes it really challenging for us to be responsive to the current issues that the healthcare system is facing and to deliver analysis and insight that is timely and impactful. What we've also learned is that creating these one-off bespoke linkages for specific projects, as part of the data sharing agreements, often these linkages have to be destroyed at the end of a project. And so the wider analytical community doesn't benefit from the new linkages that were created. So there's limited value beyond the specific projects. And you'll also know that the public discussion around trust and data sharing is very much alive. And there have been really good advances in privacy preserving models of analysis, and that is also something that I think the public want to see more and more. So back in 2018, our team saw an opportunity to work in partnership with local systems and local analytical teams to work on collaborative analysis with their linked data sets, rather than bringing in linked data sets into our own analysis environment. And what was created as a result of that idea is the Network Data Lab. So we are a network of analytical teams across the UK. We have 5 partners in North West London, in Wales, in Liverpool and Wirral, Leeds and Grampian and Aberdeen, and they're all shown here on a map. We have 3 out of the 4 nations represented, which is really great. And what you'll see by just the number of different logos on this map is that each of our partners is in itself a local partnership of different organizations, including analytical teams from the health service, commissioning groups, councils are involved. We have public health teams and universities. So that is a really nice way to also, and some of these organizations haven't worked together previously. So being part of this big network is also a really good opportunity to strengthen these local relationships and break down any silos. So what we do with our 5 partners is that we work together on analysis using their linked data sets across health and social care. And we also support these local systems to create new linkages or improve their metadata or data warehousing systems, and to embed patient and public involvement in the analysis workflow. We use a federated analysis model to do this, and our aim is to create insights that are relevant for national policy and that really showcase the value of data and linked data in particular. And what we mean with federated analysis is that we work on shared questions at each of our local sites and bring the results together. And I think Seb will tell you a little bit more about what that means in practice. Oh yeah, here's the link if you want to find out more. To give you a quick overview over the data landscape across our 5 NDR partners, you'll see that here at the top, primary care data is overall really well linked, with the exception of, I think, Scotland, where there isn't any data on GP consultations. Secondary data is available pretty much everywhere. In our experience, that is these are the data sets that are standardized to the highest level across all the 3 nations, with a big exception being mental health care, and that is the topic that we're working on at the moment. That's taken a lot of work to process and link to other data sets. It's still very fragmented, and most of the teams that we work with haven't had a lot of experience working with it. Social care remains very difficult to standardize across the different regions, and you'll see from the table here that the kind of sources their partners have access to really varies, and that is the challenge that we're hopefully going to tackle next. And what I'm showing at the bottom here is that each of our partners also has access to a unique collection of data sets, ranging from local authority data, cohort data sets, genomics data, or linkages to survey. So what we're trying to do in each of our analysis projects is to enrich our central analysis topics with insights from these unique data sets across our different partners. It's of course not all about data. We are a large multidisciplinary team across the 5 labs and the central team. We have a number of different work streams that need to come together to deliver the type of analysis that we want to do, including data stewardship, communications, how we communicate and disseminate our findings. There's of course public and patient involvement and engagement, and the analysis. One of the really key things that we did in this pilot phase was to figure out how these work streams will work together and how we work together with our different partners. And how we go about this is really important to us. So we actually put a really big emphasis on collaboration. We co-design analysis plans and analysis topics with our partners and with public, the patients and the public. We review each other's results and we share code and resources. And what is quite different to, in how we work compared to other sort of well-known initiatives and platforms is that we leave local data where it is. There is no need to transfer any data to the Health Foundation or to other teams. In our federated model, local analysts work on the local data according to shared protocols and analysis questions, and we then bring the summaries results together in a central location. And as a really nice side effect, working in this way has also enabled the local team to work on their information governance and data access procedures and to streamline them and make them and enable them to do more with the data that they already hold. We also put a lot of emphasis on quality assurance, including the review of code and outputs. Everything we produce goes through statistical disclosure control, and we peer review each other's reports. And that is part of how we try to create shared learning, both within the network and externally. We host a lot of workshops. We have a Slack workspace, engage and one-to-one engagement between the labs. And bringing all of this together, we don't only create analysis insights, but we also build analytical capability in the teams that we work with, as well as data assets that hopefully have value beyond the lifetime of the NDL itself. And finally, we involve public engagement of patients and the public across the project lifecycle, starting with how we select topics, how we interpret the results, and the type of outputs that we publish. And each of our local partners have a dedicated PPI lead. On the right side here, I'm showing an example of a blog that one of our colleagues published on how we incorporate the public perspective into the analytical work that we do. So just a quick word on what we've learned over the last 3 or so years. Working in an embedded way with people who are really part of the local systems has really helped us to ask the right kind of questions that we otherwise might not have been able to. And it's also helped us to use local relationships to drive both the demand for more analysis and how insights are being used once they've been disseminated and created. Engaging patients and the public has really helped us to create better end products, we think. And what's been really key throughout has been the relationships and collaboration between partners. But we've also learned that when you're sort of in delivery mode and trying to finish analyses, it can be really challenging to make time for that. We've landed on a very pragmatic approach to data harmonization. So we really just harmonize enough that is needed to get the current analysis project finished, rather than spend, 2 years up front harmonizing all data sets across all our partners. And working openly has really increased our reach and our impact. And again, Seb is going to show you some really practical examples what that looks like. So what have we been able to achieve so far? So we kicked off the program in 2019, and the first year was really dedicated to finding the right partners to work with. We've since then worked on our first topic, which was the impact of shielding from COVID-19 on patients, and we published a few outputs on our website and also a briefing. And again, Seb is going to show you some more results in a minute. Right now, we're working on children and young people's mental health, and there's an upcoming briefing coming out in June, so watch out for that. And we'll finish off this pilot phase with the third topic and some work to redesign it, the NDL for the future. Okay, at this point, I'm going to hand off to Seb, who will talk about how all of this works in practice.
Brilliant, thanks, Fiona. Is it okay if you go through the slides? I'll just let you know. Fab. Yeah, so I'll pick up from here and I'll show you kind of how the program works in practice. And I'll do this by going topic by topic and showing you also kind of how our ways of working have evolved as a team. So I'll start with topic 1, which was our pilot analysis. We started this in the summer of 2020, a few months into the pandemic. And it being a pilot phase, it allowed us to get to know our labs and figure out how we would work together, which wasn't always easy because at the time, some of our team members in the NHS, for example, were being pulled into the COVID response. That also meant that, you know, when it came to choosing a first topic, we knew that it had to be something related to COVID. And after reaching out to patients and other members of the public, we agreed that we should do something on people who at the time were being asked to shield. So these are what were referred to as clinically extremely vulnerable people, or you might hear me say CEV going forward, which is just the acronym. From a data perspective, it was also a really relevant topic for us because linked data is exactly how the NHS identified CEV people. First, they did this by scraping people's healthcare records using different codes, and then this evolved into more fancy algorithms that predicted someone's risk of having a severe outcome, for example. And yeah, at the time, we didn't know if vaccines would work, how long this policy would be in place. So it seemed something really relevant for us to tackle. We focused on 4 questions. Number 1, how CV people were identified by local and national systems. So whether this was done using algorithms or by hand. Then we described who they were in terms of demographics and what are the conditions they might have. And we also looked into how their hospital care was affected by the lockdowns and changes in the NHS, which is really important because a lot of them relied on hospital care quite frequently for treatments like dialysis or chemotherapy. And last but not least, we also looked at how their mental health was impacted. Next slide, please. Yeah, before I show you the results, I want to quickly say a word about how we work together. So we had 2 different layers to the analysis. And the first one is what we call the central analysis. So that's the bubble you see in the middle. So for this central analysis, each lab followed exactly the same protocol. So, for example, when we were describing comorbidities, that means that everyone used the same conditions, the same ICD-10 codes, the same look-back period, etc., which means that at the end we had 5 copies of the same analysis, but with different findings, of course. We found that it worked well for 2 reasons. So number 1, it was easy to aggregate results into a single figure. So the NDL covers an area that's about 8 million people. So it can be, you know, where this is nationally relevant, it can be quite powerful to aggregate a result into a single number. And number 2, it worked well because everybody was working on the same thing. It also meant that it was a bit easier for people to collaborate. On the other hand, however, we found that these local data sets are so different that we couldn't always harmonize everything. So there were perhaps other really interesting questions that we would have liked to ask, but we weren't able to. So to kind of counteract the central analysis, we also asked each lab to work on a separate satellite report. So that's the ring like on the outside, where they had a lot more freedom to pick their own approach and to use data that maybe other labs didn't have. Next slide, please. So in practice, how do we collaborate? How do we stay in touch? How do we get together? So we see each other pretty regularly, virtually, of course. We have, especially when we're in like the middle of doing the analysis, we have monthly workshops. We are starting to have learning sessions where we spotlight some of the labs to, teach us about something specific to them. Usually kind of the busiest time for us is when we're in the middle of topic selection. So, choosing the questions that we're going to answer, or also when it comes to interpreting findings and we're in the middle of writing something. So like right now, for example, we encourage people to use GitHub, and we publish quite a lot of repos. So I encourage you to visit our GitHub landing page, where you'll find lots of useful R and SQL code, especially at the moment on the mental health side of things. So which is what we've been working on. So things like clinical code lists, data cleaning pipelines, etc. Next slide, please. Yeah. So yeah, enough about our ways of working. I'll quickly take you through the results from the CV analysis. So I always have to say this when I show the results, but nobody can really say whether shielding worked or didn't work, because there's no, counterfactual out there of, for the COVID-19 pandemic where people didn't shield. So that's not what we set out to do, but we could say a few things from our descriptive analysis. One of them was that shielding didn't fully protect people who were the most vulnerable. One very clear example is mortality rates. So CV people were dying at 3 times the rate as everyone else, and that's even adjusting for age. Another important finding is that people who were asked to shield did experience worse mental health during the pandemic. And that makes sense, on top of having to cope with a serious condition like cancer or COPD. They also had to deal with isolation on top of that. So our analyses did show that they were more likely to look for support for their mental health. And third, we found that changes to the NHS, so for example, when hospitals stopped elective procedures for some time, affected them more than they affected other people. When you keep in mind that a lot of them have to manage complex conditions, and often in hospital, this is a really worrying finding, which led us to recommend that the NHS should prioritize this group of people for access to care. The final message was around some flaws, I can say, in the algorithms that were used to implement this policy. Some of it came from just, poor quality data in healthcare records, which meant that people had to be added manually, either by themselves or by their GPs. And yeah, I think the message here is that if there's another health emergency, we'll need better health records in order to identify who's the most vulnerable. Yeah, next slide. And to wrap up this topic, I'll just tell you a bit about impact, because this was a really great topic to work on, because it felt like we asked some really important questions, and we also managed to have quite a bit of impact. So first of all, we worked quite closely with the team at the HSE, who was in charge of the shielding policy, which meant that they were able to tell us what kind of analysis they would find useful. And that meant that we could go and make it part of our analysis plan. So in a way, it was quite reactive. because we were able to feed results directly to them based on what they needed. And we also were able to put them in touch with some of the local teams so that they could find out more about the local linkages that were enabling this. We had a briefing come out last year, as Fiona said, which was very well received, and it was covered in major national outlets and also in local publications where each of our labs are based. We also had some really good impact from the satellite reports, so the local reports. For example, the work that our partners in Aberdeen did, hi Jess, on how well algorithms performed. They ended up helping shape the approach of their local NHS board on how to identify vulnerable people. Next slide. Great. So for the last few minutes, I'll quickly talk about the analysis that Fiona and I and the NDA and the labs, of course, are working on right now, which is children and young people's mental health. So in a way, we're kind of continuing on the very broad topic of vulnerable groups, which which is, I think, one of the NDL priorities because we're so focused on health inequalities. It's a really relevant topic because, as you may know, mental health conditions are and have been on the rise among children and young people. There's been the impact of the pandemic, definitely. For example, a lot of children were kept out of school, or they were apart from their extended families. But this has been going on for longer. I'll just pull out some quick survey data here. In 2021, it was estimated that 1 in 6 of 6 to 16-year-olds had a probable mental health condition. In some groups, it's even higher. In adolescent girls, it's almost 1 in 4. So it's a really big issue. And from a policy perspective, you might know that mental health services for children are very hard to get into. And even once you're accepted, waiting times are very, very long. It's also a really good opportunity for us to showcase the value of linked data because, as Fiona said earlier, mental health care is very fragmented in the way that it's delivered. And the data sets, so things like MHSDS or the CAMS data sets, they're notoriously complicated to work with. So the NDL, it's been a really good opportunity to give partners the time and the resource to bring in these new data sets and kind of become experts in them. So yeah, our labs have been busy doing some really innovative work on this topic. Next slide. I'll just tell you a bit about how we've been working. Yeah, so this time around, we changed the ways of working a bit, and essentially we just dropped the central analysis. And the reasoning for this was that we wanted partners to be able to fully take advantage of what makes their data unique without having to make compromises for the sake of harmonizing their data. And it's worked really well. So we've seen some really novel applications. And it also means that they can pick topics that are really relevant to their local audience and feed those results straight to the policymakers and the clinicians who are the end users. On the flip side, it's also been a bit more challenging to find ways of collaborating just because everybody's been a bit more kind of working in silos. So yeah, we'll keep experimenting with ways of working until we find something that kind of, hits both targets. And yeah, so before we stop presenting, I just want to show you some examples of the mental health work that the labs have been doing, which are all just still at this stage preliminary results, I would call them. So yeah, if just I would ask you not to share this with anyone else for now. Fiona, can we go to the Welsh slide? Yeah, next one. Yeah. So in Wales, our brilliant partners at Public Health Wales, they were able to get data from the ambulance service and link this to the rest of hospital records. So this Sankey chart that you're seeing here, it shows you that emergency admissions are actually quite a small part of people's care when they have a mental health crisis. And a lot of the care is actually being delivered by dispatch operators or the ambulance crew. And you would never be able to see this without having that linkage in place. They were also able to link this with a substance misuse data set. So they were able to quantify just how much, that this is a group with a much higher use or incidence of crisis care. Next slide. And in Aberdeen, they've done a lot of work, but among other things, they managed to focus on drug prescriptions, which gave us a bit of clinical insights into what conditions are affecting young people. So they found that in the kind of primary school age groups, in terms of medications, people tend to receive ADHD medications, and it's mostly for boys. But when they get older, so for example, in secondary school or older teenagers, it's really antidepressants that take over. And it skews a lot more towards girls in this age group. They've also done a lot of work on referrals to CAMS and rejections. And a really nice example of impact is that they were able to use these results to ask for more clinical consultants. Next slide. In Leeds, so our partners in the CCG and in the City Council focused on how they focused on the transition from children's services to adult services. So around the age of 18, if you're being taken care of by a mental health team, you'll transition to the adult service. And so here they're showing the drop in, so to speak, retention as soon as people turn 18. And it also looks like children are moving from more long-term care when they're children to what looks like quicker or more short-term care adults. So this might be an issue for some adolescents who are used to a more intensive type of follow-up. And the last case study. So this is Liverpool and Wirral, the two CCGs working together. They were able to link the data on routine mental health contacts to the rest of the data on emergency admissions and A&E attendances. And by doing this at a very local area, they were able to identify places that have different patterns. So for example, the map that you're seeing here is on the right-hand side of the Mersey, the river, that's Liverpool. And on the left, that's the Wirral. And they found that in some areas, you have young people who are not using or perhaps not able to access planned mental health care, like, for example, an outpatient service with therapy, but they are showing up quite a lot in A&E or emergency departments. So this is the type of information that will be really helpful to the local authorities so that they can keep targeting services to areas where they're needed the most. So I think I'll finish on that note, and Fiona and I will stay on to answer any questions that you might have for us.
Thanks, Fiona. Thanks, Seb. That's a really good insight into the work that you're doing and how you're doing it. We haven't got any. I don't think we've got any questions precisely for you. I've got a question which I think could definitely answer, but it's not necessarily relevant to what you've just been talking about. So I'm going to put that one up first because I think it's a very good question. It basically says how to be a good analyst and how to progress. So do you have it? So aside from what you've just been talking about, what would your answer be to that? Who wants to answer that? Fiona or Seb?
How to be a good analyst.
How to progress. So so what makes a good analyst in your experience?
Are you about to say something, Seb?
Yeah, I would say just like really simply, for example, we've seen great examples of our work from what people might call descriptive statistics. And I think those have had like a huge amount of impact, and they've actually been quite difficult to produce. A lot of the innovation is in the data itself. So I think I would just say that I think we're very proud of doing descriptive statistics most of the time, and that fancy models have like their time and place, but it's not always the time and place.
I think that's right. Actually, I think there's so many of us do descriptive statistics, and we don't do fancy stuff. But it's so important, and in order to do those sort of descriptive statistics and beyond, you've got to sort that data out, and you've got to and that is 90% of where you're at with a lot of these things, especially novel work. Yeah, so I totally agree with that. And Fiona, were you going to come in?
I think you're making a really good point. I think even the simplest statistics, it's really hard to do that well. Sometimes we're just counting things, but doing that well is not an easy thing to do. So I mean, the first thing that popped into my head with this question is probably to be a good analyst, you just have to be really curious about your data, about the quirks in it, about the methodology, about how to code, and to also be your own, I guess, most critical peer reviewer and put yourself in the shoes of the people who are going to consume your analysis. And whenever you present an analysis or write it up, to really think about, well, is this what I'm doing and what I'm presenting here obvious to the person who will read it?
Yeah, definitely. And it's very much about, there's so many actual things we talk about here, but it's the relationship with the person who is asking that question. It's understanding what they are needing it for, and then maybe challenging them to get that question right in the first place before you go away and spend hours and days and weeks doing an analysis. I do have a hand up from Ian. Ian, did you want to come in there?
Just to reinforce those points, data doesn't talk by itself. Well, it might talk to you as an analyst, but the narrative, how you play that message, very important, I feel. Yeah, so yes, I agreed.
No, definitely, and that's so right. You can do the most amazing analysis, and it can be robust, and all the findings can be there, and it can be stark. But if you're not able to translate that to people in a way that they can actually use it, then it's not going to be much use. I'd only I suppose the other, before we sort of move on to another point that's been raised here, is I would say, from who's posing that question is an analyst in the Midlands, we've got lots of training opportunities which are out there as well, and networking opportunities for you to sort of talk to other analysts and sort of develop your skills wherever you are in your career. There's an awful lot of resources out there. In fact, there's almost too much, so it can be a bit bewildering. I realise that, to sort of navigate your way through all of the training opportunities and resources out there, especially sort of since COVID, when there's been a lot more onlineness. It's a new word, isn't it? Anyway, so another point, someone said, can you share more on how you do peer review and quality assurance?
Yeah,
I give that to Fiona.
I can make a start, and then maybe Seb can add things. I mean, there's several elements, I think, how we do peer review within the lab. So we when our partner share our results with us, share their results with us, we review them and ask for clarifications and see that everything makes sense. And obviously we want to bring it together into a narrative, so they also need to I guess complement each other well and follow similar methodologies if possible. There's also external peer reviews, so some of our partners publish peer reviews paper, so that there'll be a whole external process as well. In addition, we generally publish all our code, and I think even some analysis results on our GitHub page, so it's for everyone out there to see and check and criticize or reuse, whatever really they would like to do with it. So I think that being really transparent and open about how we use the data and how we arrive at the results that we present helps with that. We also, I think, normally write technical appendices for our briefings for people who want to find more about how the analysis is done.
Okay. Nothing to add really, but just to say that try to be very transparent in everything that we do, and that also kind of it's the best way really when you're done with your briefing and you know that everything's out there and you've shown everyone how you've done it, you kind of sleep a bit better as well.
Okay, thanks for that. I'm just sort of looking at a couple more comments as they come in. So someone is saying that we don't really do peer review in day-to-day work as a team. So it's maybe I like this one. It's maybe a good topic for a future huddle. Totally agree. And there's another comment around it's all great work, and wondering it's the relative role of the Health Foundation and NHS and other ICS organisations, and the balance between you doing this type of work and organisations doing that for, or systems doing that for themselves. So the actual question was, all great work. Why does it need the Health Foundation? How can we do this? How can we do this for ourselves?
Yeah, it's a really big one, big question.
I know,
and a really good one as well. I mean, there are obviously other organisations and networks in this space, with the strategy unit and their network being a really good example. I think maybe something that we can bring to the table as the Health Foundation is obviously the ability to fund some extra work and to provide teams with the time and space that they might otherwise not have. And being an independent organization, the analysis and sort of recommendations that we produce centrally, I guess that the consumers of our analysis can be sure that it has been produced independently, and I think that is generally appreciated about the work that we do. I would be curious to hear other people's views on this as well. I don't know, Seb or anyone else in the audience.
I would just add that these linkages they were already, most of them, in place before we came in. So to some extent, local systems were already doing it by themselves, but we're kind of bringing them together and showing everyone else. Yeah,
because it is a requirement of all sort of integrated care systems to develop those record linkage.
Yeah.
And I guess that's being successful to varying degrees and to varying extents. So we have another big question. You're loving this, aren't you? They could be about anything, but no, this is.
There's a raised hand as well. Oh, it's gone now.
Oh, okay. If someone's it's come back. Stephen Wyatt, what would you like to say?
Thanks, Fiona. Rachel. Yeah, I just wanted to sort of to come in on that question we just had about the role of the Health Foundation. So this is this topic you're tackling is something that's been around for a long time in the NHS. Some people have made progress, others haven't. And I kind of see your role as a catalyst, really, putting in some extra energy, some extra funding to help us get over some of the hurdles that we've been struggling with. And if you can push us on in a few areas around the country, show what's possible, I think that'd be some fantastic contribution you're making. I had a follow-up question, which I was going to ask, if that's all right, Rachel, which might be the one I've already posted it on the thing, but it's really about what you would recommend to government agencies if they want to really mainstream data linkage. What would you recommend to them to make this, to help areas overcome the barriers? Because they all want to do it. Everyone wants to do this stuff, but we have struggled in some areas to make it happen. So what would your recommendations be to the national agencies and to government to make it more feasible?
That's a tricky one. And I don't know whether that quite answers your question, but the first thing I was thinking about was sort of how these local processes and IG arrangement, data sharing agreement could be streamlined and harmonized. I know that our partners spend an awful lot of time going through various different data sharing processes and linkage processes, which seems to be a big barrier towards, how our partners work locally. And I think if that could be streamlined, harmonized, so that work that has been done previously can be reused and adapted for the next linkage and the next project, that would speed things up a lot. That's a very technical aspect here, but I think it's an important one.
It feels like to me that the agencies that sign off the data sharing agreements, it's almost as if we have to play a bit of a guessing game, trying to work out what it is that would be acceptable to them. And it would be great if the sort of paradigm was reversed somehow, and they provided the templates for acceptable data sharing arrangements that we could just then decide, well, is that satisfactory to us as users? And if it is, then we'll just sign up to it, knowing that all the IG for those sorts of arrangements have already been cleared and authorised. That it would be, I think, a massive step forward if they could take responsibility for setting out what is acceptable and what they would automatically sign off, rather than us trying to constantly guess what it is we have to say in our applications to get over the hurdles. It would save a huge amount of time and energy, I think, with health systems if that approach were taken.
Yeah, something that we're planning in the near future is to bring together a lot of these learnings from our data stewardship work stream, what we've learned across our 5 partners, and to take them to forums like these, to hopefully make a wider group of people benefit from what we've learned over the last years.
Yeah, that would be good, actually. I'm just thinking sort of back to those data sharing agreements. I mean, they're basically everybody's favourite, aren't they? Everybody loves to do them. They love to think about them. They think about a project and they think, oh, great, before I get stuck in, I need to do 3 data sharing agreements. So it is, it's from my experience and many people who are involved with sort of project work and beyond, it is a barrier. And so much so that you don't even bother with the question, because it means I've got to actually negotiate or sort of resolve these issues with this mental health data or this social care data, whatever it may be. So I agree, Stephen. I think that's a great idea. So because you have a lot of people spending a lot of time in local areas, all organisations, sort of satisfying GDPR criteria, and a lot of people employed to invent all of these things. But there's probably at the top of the pyramid, there's just a few people. If they were just able to sort of flip it around a bit, I think that's a good idea. Well done. Yes, we'll enact that. Okay. Well, that's. I don't think we have any more questions. That's been excellent. Thank you very much. I really enjoyed. I really enjoyed that, and I'm just going. So before I say goodbye, I'm just going to, before I let people go, I just got 1 or 2 things I would like to mention to other people about the up and coming huddles, of course. So I'm just going to share my screen again, so we can just see what's coming next. And actually, you can stay right there. Oh no, you're not on it. Oh, that was embarrassing. So you will be here in about 3 or 4 huddles time, Stephen, but not. It's the right screen. Let's have a look. Can you see something sensible? Yay. So next time we have David Callahan. He's from the strategy unit. You might know him already. He's going to come and talk to us about the integrated care systems intelligence function guidance. It's a bit of a mouthful, but you'll all get to hear about this sometime soon, and the implications of it. It's not just about intelligence, really. It's about decision making and analysis. It's relevant to all of us and important too. And then we've definitely got Andy in the audience, so he's going to be coming to talk to us about public health management impactability. And so I'm really looking forward to that too. And talked about a couple of times ago, we wanted to have a huddle on maternity. We've not covered that. So we're going to be talking about maternity and building links with other analysts. And I haven't corrected this in maternity. It's okay because I'm not recording it, but I am. So just wanted to give you a quick update too on our training and development programme. So where are we now? We're in March, so we are thinking carefully about what we're going to be putting on next year. But here's a flavour of what's going on at the moment. So we've got a theory of constraints for patient flow, which is a 1-day course, and there's 3 dates. The first one is tomorrow, so you've missed the boat on that, but there are 2 other dates, so do look at the website and get yourself booked on to those if you can. Alex Knight is an expert in this area, and of course he's written several books, and I've checked him out on YouTube, so it's really good. So I totally recommend that, and that'd be very, very useful actually. There's also the communication skills series, so we have our friends Campus PR, who are comms experts, and they are delivering this training program. So there's 3 half days for that one. So the first one was 1 day. This is three half days over 3 weeks, and that's really a non-technical program, and I think that would be appealing to a lot of people. So think carefully about who goes on that. It's non-technical, but there's a lot of really good ideas and some from their professional perspective and their experience. I think it'll sort of shed some light on and give some ideas as to how to improve that for you or analysts that you know. And then I'm very excited that we've got 2 more cohorts at least of the Leadership Development for Analysts program. Now that's been very successful so far, and people have really enjoyed that, and we've had a lot of interest, not just from the Midlands, because it's covering ground we think that isn't really being covered in this way in other areas, because we saw it as something that was needed. And we're even going to be very brave and thinking one of these is going to be a residential. So might ask you whether that's something that you want, or we might just go ahead and arrange that, and then the other 1 or 2 will be online. And the thing about that is, so Lucy Hawkins, who's the program lead for that course, she is going on maternity leave, so I'll be taking that on. So hopefully I can continue the good work in Lucy's absence. And the last course I'm just going to mention here is Fraser Batty is doing, strategy unit is doing a number of face-to-face workshops on thinking tools and how to be an economist. So those are going to be taking place face-to-face in Birmingham to begin with. And the first one is on the 12th of April. I'm going to be emailing you about that very soon. Okay, so if I can just, I won't allow myself to go over time. That would be terrible. Okay, well, thanks again, Fiona and Seb, and everybody for coming as well. It's always great to see you all, and I'll see you all again in a couple of weeks. Okay, bye-bye.
Thank you. Bye-bye.